Brief introduction. Unicondylar knee replacement is touted as more conservative bone and tissue sparing procedure. And this procedure has come up recently and is gaining a wide interest across the globe. However, the revision of unicondylar knee replacement is 3 times more often earlier than total knee replacement. There has been promising clinical outcomes, but survivorship is unpredictable. So pondering upon these thoughts, my case report here is for you. My case report is a 72-year-old lady with a unicompartmental knee, and she was very physiologically active young lady with a low BMI and with no comorbidities. So looking at the x-rays, as you can see, she has isolated medial compartment involvement. She didn't have any clinical mechanical deformities, and her patellofemoral joint was quite normal. Since she was an active lady and we gave her the choices, and she agreed happily for a unicondylar knee replacement, which was carried out in March 2016. She underwent one after the other, the left first and then followed by the right. And she had a functionally good results, and she was asymptomatic for almost 3 years. 3 years down the line, she started developing progressive pain on the right knee. Subsequently, we did an X-ray, and we also noticed there is a malgraded femoral components and loss of joint line, as you can appreciate in the AP views. Similarly, on the lateral views, there is excessive posterior sloping of the tibial plate, as noticed on the right side, as you can compare it with the left side, which is clearly evident. And in the meantime, the COVID pandemic struck, and she was kind of not approachable, or she was kind of lost to follow up. And our hospital also became a COVID serving hospital, so where all major surgeries were shut down. So coming again, she came back after a year, and here you can see again the condition of the patient worsened. She had aggravated right knee pain, and from the x-rays we could clearly make out there is aseptic loosening of the components. However, the left knee was asymptomatic. So looking at the x-rays, we decided to offer her something, and the choices were pretty clear for her. And these were our operative challenges: the loss of bone on the tibial side, the pre-existing scar of the unicondylar knee replacement, leaving a scar which can cause a flap necrosis if you approach the knee at the midline. There were always a fear of infection because the knee was not virgin. It has been already operated. The chances of infections are already high. And there were chances of causing an iatrogenic fracture during component extraction of the pre-existing right knee. So these were our operative challenges. But meticulous planning was done, and the patient was taken up for surgery, where we did a standard regular knee replacement using a midline incision, and the components was found to be totally loose, and it was easily extractable. There was no evidence of any infection inside the joint, and however, it was confirmed by a quick swab, and we had sent to our lab intraoperatively looking for gram stainings. And after the removal of components, a minimal cut was taken on the tibia side, and we were able to restore the joint line with the cement mantle, as you can see in the lateral views. This patient was followed up continuously and monitored with serial x-rays. And this is our latest x-rays, which was done in 2021. The right total knee replacement is almost a year now, and the left unicondylar knee is almost 5 years down the line. So as you can see, her x-rays clearly shows that the left knee is doing well with the UKR, but the right knee is also doing pretty well with the total knee replacement after a year. These are the postoperative images, and looking at her functions, she had a good range of motion. Her scars have healed well on the right side. As you can see clearly, there are 2 scars on the right side, and her knee scores considerably improved from 55 to 85 using course. Coming on to the literature review, there are not many literatures come out with recent data, but whatever I could find was around 3-4 years back. And this is the main one of the main important literature, which is done by Harshvardhan Chawla et al., which has compared the revision rates of partial versus total knee arthroplasty in his meta-analysis. He clearly explains that it is a lower survivorship of unicondylar knees, and which is highly likely to have aseptic loosening. Aseptic loosening is diagnosed by the presence of radial loose inclined, which we were able to appreciate with a regular follow-up, and especially in a center with a low volume center, it is very difficult for the surgeons to pick up these kind of radial loose inclines. And also it says that the 40% of the late UKA failures are due to nothing but a mechanical shortcoming of the implant, and this reflects the natural history of pathologic process. Another review of literature done by Martigin et al., which also says revision of partial to total knee with the use of basic patient-specific instruments. The main challenge in conversion of partial to total revision surgery is the rotational alignment to restore the rotational alignment of the femoral components. But adequate preoperative planning is mandatory, and you need to have necessary armamentarium at your table. It is technically demanding procedure because the anatomy does not deliver clear landmarks, which makes it difficult to track the location and position of the joint line and axis. Similarly, another paper by Bekerens et al., it also states that the reason for revision include loosening of the components, most common, subluxation of the bearing or impingement, and progression of osteoarthritis, which is the natural course of the disease. So these studies also help us to inform the patient what to expect from the revision surgeries, highlighting that the revision of uni to total is might be warranted in the later year of their life. In our case, we did identify loosening with a regular follow-up and x-rays. What was advantageous to our side was the minimum bone loss on the tibial side and minimal varus deformity. There was no any stress fracture around the components. We were able to recreate the native joint line with minimal resection and bone cement mantle restoration. And we use our standard posterior stabilized implant. So conclusions is basically that conversion of uni to total is a technically challenging surgery. Adequate pre-op planning is a must. Necessary armamentarium like stems and wedges should be available on the table. And standard implant can be used as a rescue for all these failing cases if there is no much of bone loss and there is no evidence of any stress fracture on the medial side or any of the components. Thank you. And these are my references.